Today, I'm going to interview Dr. William Walsh, the author of Nutrient Power and also founder of Walsh Research Institute. Dr. Walsh has been training psychiatrists like myself to utilize his methodology to help people with mental illness using nutrients in addition to medication. It has been part of our integrative mental health program, and we have had incredible success with his protocol and his series. Hi, Dr. Walsh. So thank you so much for doing this interview with me, and I hope it will benefit my audience in both Chinese community and also my patients here in the United States. I would like to start asking you to really introduce yourself and your journey and to develop this wonderful, what I call WASH protocol for mental health.
Well, it all started by accident. I'd like to be able to say that I had planned all of this, but no, the truth is it was all accidental. I got very interested in university in nuclear science, and I got involved in nuclear physics and nuclear engineering. My PhD was in chemical engineering, but I've never been a chemical engineer. And I worked for places like Los Alamos, the Institute for Atomic Research. I got involved in places like Oak Ridge and others. And I was in love with physics, of nuclear physics. But eventually, I came to believe that wasn't necessarily the best thing for society. And I got interested in you might say, more environmental kinds of things. And I got involved in at Argonne National Laboratory as a young scientist. I got really interested in doing a bit of nuclear chemistry, trying to find out ways to safely get plutonium and uranium out of fuel elements safely. And I decided that wasn't going to work out too well for society long range, because there's going to be still problems 1,000 years from now. So I got involved with energy, and I became head of a fairly large group, electrochemistry. Within a year, I got lucky and I invented a lithium battery. I got the patent for it, and it was a very early lithium battery, and I got a national award for it. And I got invited to give lectures around the world on that. So electrochemistry for me for about 10 years was what I was doing. But along the way, I got interested in social things. And a lot of my friends were volunteering and getting involved with helping other countries. And I got interested in crime and violence. In our neighborhood, one of our neighbors was thoughtlessly just shot and killed just driving down the street of Joliet, Illinois. I decided to see if there's anything I could do to possibly make some contribution to that. So eventually, within a year, I was at a place called Stateville Correctional Center, one of America's toughest prisons. I started with a chess match. I was head of the Argonne chess team that had just won the Midwest Championship. We heard they got a good team at the prison, so I organized a meeting, a game between PhD scientists and a bunch of criminals out of 4,000 people there. And the man I played had just gotten off death row. We spent a lot of time, and one thing led to another. Within a couple of years, I was the head of an organization called Prisoner Assistance Program. I got an award from the United Way of Chicago as the Prison Volunteer of the Year for Metropolitan Chicago. And I was really engrossed in trying to help these people. But my education started an ex-offender program, trying to help people when I got out of prison. What I found was a lot of the parents were saying that their other children were fine, but this one child was different from the day he was born. Oppositional, defiant, harming their pets. And they convinced me that there was something wrong in the beginning, that it wasn't just the environment and trauma. And so that's how it all started, by accident. I started while I was at a scientific organization with world-class chemists, and eventually I had 125 people in my group doing either scientific studies or just visiting criminals, trying to help them and try to help them interact in society. And that's how it started. While after the first year, I had a lot of data that didn't make any sense. It was like taking a shotgun in the wall and you see all the meaningless data. And I just happened to attend a talk by Dr. Carl Pfeiffer, who at that time was considered the world's leading nutritional scientist And he had just been nominated for a Nobel Prize for his work in schizophrenia. And I got to meet the man, and he thought what I was doing was interesting and important, and he gave me some suggestions, which I followed. He said that when he started his work, he got his best results looking at metal metabolism, things like copper and zinc, manganese, and toxic metals. And so that just got me started. And within a few years, I decided this is more important than my scientific research. I gave a couple months' notice and started a scientific organization, a public charity. So we're doing this, and it's now 25 years later. That's how it all started. And we began working with behavior disordered children and adults, very violent people leaving prison, but also young children with extraordinary problems. And we found out something that was disappointing and something that was really exciting. The disappointing thing was, yes, the criminals we tested and treated, and there were many of them, more than 800 felons, including many convicted murderers and sociopaths. And we learned a lot about their chemistry, but we found that the treatment programs we gave them seemed to be very successful for maybe 6 months or a year. But then 5 years later, we found out they were all back in prison, almost all of them. And very disappointing. And we found out it has a lot to do with if they were already involved with drugs and alcohol. And also they had a self-image of being criminals and hurting people. But that was the bad news. We still have never learned how to take these violent people and turn them into pussycats. But the good news was that the violent children with the same chemistry headed for prison, they did really well. We had to get them early enough. And so then I started a clinic that eventually had about 50 employees. And we were one of the largest clinics in the world for a while for nutritional work, number of doctors, nurses, and all. We expanded into schizophrenia, depression, anxiety, and then more recently, autism and Alzheimer's. So that's a summary of what happened. I was requested by a couple of countries, namely Norway and Australia, that wanted to learn our protocols for normalizing chemistry. So that started a training program. And my original goal was to teach these protocols. The way to use nutrient therapy really is I think of it as nutritional psychiatry, where we've learned that nutrients can actually adjust neurotransmission and directly affect and improve brain function. So now my original goal was to get this information to 1,000 doctors throughout the world. We've just achieved that goal, and it's getting faster and actually expanding. So we now have about more than 1,000 talented doctors like you around the world who are helping patients using these techniques that work together with medications and work together with counseling. They're in harmony with those. They can greatly reduce the need for medication and, of course, side effects. And the most important thing is for them to have a better quality of life. So I think that's the summary of it all.
I was excited that you had a largest clinic that provided nutritional therapy for mental illness almost like 20 some years ago. And I'm curious about what happened to that clinic. And the second is not really question, is testimonial, because I'm one of the students studied with you almost like 10 years ago. And we have utilized the protocol in our clinical practice. There are a few patients who can only afford to do nutritional therapies because we offer other modalities in combination with nutritional therapy. But we have a few cases they'll only do the nutritional therapy and had incredible results, purely a credit to your protocol. And we have young man who been diagnosed with OCD, Tourette's, and ADHD. And we had a young woman who was diagnosed with schizoaffective disorder, hospitalized many times. We have a gentleman who suffered from OCD all his life, and they all got literally kind of, I wouldn't say cured, but began to have a normal function without medication after year or 2 years treatments. And so that's really, really valuable kind of for us and for the patients. this type of treatments is really what people are looking for? And how come the clinic did not thrive?
The clinic was thriving beautifully. But one problem was that in the beginning, we started a very humble group. There were only 3 or 4 of us. It just grew and grew and grew. We got national attention, been on national television in USA several times. And we just found ourselves flooded with, not exaggerating, tens of thousands of requests for treatment at our clinic. And we just grew and grew and grew. Problem is, I didn't like being the boss, for one thing. And I didn't like working with accountants, lawyers. And I didn't like that part of it, the business part of it. So I stepped down and gave up all my power. And I got the title of chief scientist at the Pfeiffer Treatment Center. And everything went beautifully for several years until the board of directors began to change. And they started taking a different approach. Then eventually I felt I had to leave. So I parted ways. I left and started the Walsh Research Institute, a public charity. Since I already had worked with many, many doctors, and it was already training doctors, I thought the best use for us was to focus on research. And we're very active in scientific research, and it's going really well, by the way. And also continuing to communicate with doctors and just get the word out to people like yourself. And I'm very delighted that you have taken on the responsibility of starting an effort in China to give this information to doctors in China. There's a doctor in Japan who's doing what you're doing. In other words, he has now got a large number of doctors who are, and has leadership in doing this. There's a man and a doctor in Norway who's doing this. So I'm totally in support of what you're doing and I'd like to help you.
Well, thank you so much for the information. That's really a good lesson to learn, how we do not lose our vision and the mission in our medical practice. I think that's really sad.
It is. It was very sad, but it was, I think, something that was wonderful for me, because if I was still there, I would have never written the book I wrote. I would have never been able to expand training.
In the Chinese philosophy, there's always the good side of a bet. So there's
absolutely
2 sides of one matter. So
what looks like something terrible might be something wonderful.
Yeah,
that's what we've experienced.
That's great. Now, well, to help our audience to understand your work, I think we're going to talk about something more specific from the advanced nutrient therapy perspective, from the mechanism behind the modalities. So I'm going to just go through a common conditions that people are suffering from, and just get your summary of what the advanced nutrient therapy would provide and why. And let's start with, of course, the depression first. And what would you tell people who suffer from depression, and what is available for them from the nutritional perspective?
Well, there's a few things that we've learned even quite recently, but depression generally has a genetic predisposition, where some people are born with this tendency. However, most people with depression, it has an onset where it suddenly gets worse, either in teenage years or later. And the question is, what happened? We're now learning this has a lot to do with loss of DNA integrity and it changes that can be permanent, in which some of your key neurotransmitters are misbehaving. And we've learned that we have the ability with nutrients to adjust the genetic expression of misbehaving genes that can adjust neurotransmission. In other words, most people with clinical depression, I'd say the majority probably have what we call undermethylated version of it. And we're learning that has to do with undermethylation of their DNA, their global DNA during the 9 months of gestation, that when the baby is born, they don't have these regulating methyl marks in the right places. And so when we diagnose a patient with undermethylation, that we already know it's very likely they have diminished or insufficient activity at serotonin receptors, And recently, we now know they have too much activity at NMDA receptors. And so that's one expression. We've also learned that depression is a name given to, I call it an umbrella term. And it's an expression given to at least 5 completely different conditions. I presented this at the annual meeting of the American Psychiatric Association. I thought they might throw me out, but they didn't. They were nice to me. I had this huge group of psychiatrists, and I basically was explaining that they were doing depression all wrong, and that I had this huge, probably the world's biggest chemistry database for depression. And it was very clear that there are completely different diseases now called depression. And as you know, for example, some of them simply have metal metabolism disorder involving extraordinary inability to keep copper levels regulated. Copper levels have a lot to do with dopamine and norepinephrine. It has a massive effect if it's not regulated. That's 17% of all people with depression. And then there are other types. There are what we call the pyrrole depressives. And these are people born with extraordinary oxidative overload, and it's inborn. We now understand why people have this condition. It has to do with genetic weakness in the natural antioxidant protectors that we have. A lot of people have weakness in that, and also weakness in DNA repair. They can't protect their DNA. We're learning more and more that conditions like depression, schizophrenia, and all are related to primarily to loss of DNA integrity, which is why we age. It's also why the basic reason why people develop these disorders. But we do have, we've now been able to, for depression, a depressed patient comes to a psychiatrist, typically in the world, they spend their half an hour wondering, I wonder what medication I can give them. But we now have, since I gave that talk at the APA, we now, the most enthusiastic doctors we have are psychiatrists. And there are more and more and more of them want to learn how to do this. So then when the first time they see a patient, they'll do some lab tests and they'll find out whether they have imbalances in metal metabolism, whether they have a methylation imbalances, whether they have a pyrrole problem, etc. And that can tell them, that can guide them to nutrient therapy that can really help them. It also can guide them to which medication to give them. So it's more scientific. And I think this is going to grow and grow. And that's why we're trying to give this information to as many doctors around the world as we can. And it's going well.
Great. A specific question regarding medication selections. Let's say people who are undermethylated, supposedly having lower serotonin level. And
Yes.
And do they also have a dopamine or norepinephrine deficiency as well?
Yes, in general, and there are exceptions, but usually 95% of the time, if a person has low serotonin activity, they tend to have low dopamine activity. And the reason is it's controlled by reuptake, not the amount of dopamine or serotonin in the body, but really the rate at which the neurotransmitters in a synapse can immediately go back to the original neuron. And reuptake is controlled by serotonin. That's controlled by a gene called a SERT gene, S-E-R-T, serotonin transporter program. And that's what produces the passageways at the neurons for the serotonin to go back into the original cell to reuptake. And we can control that. We can regulate that by changing methylation status. And so if a person's undermethylated, we almost certainly know that they also have symptoms and traits associated with that. It's not because their body's methylation is undermethylated. It's because of their DNA methylation. I call it global DNA methylation. If their DNA has low methylation, if they're undermethylated, then they will tend to be competitive. They'll be perfectionistic. They'll be prone to OCD. They'll be prone to addictions. They'll have these classic traits. And that's why when we treat methylation, people who have these traits, they still have those same traits after we normalize the methylation in the body. It's because it's controlled by their methyl bookmarks on their DNA, and they don't change. So that's why those things tend to be the same. So we're learning a lot about how to help people. For depression, now got the 5 major types of depression, and we got individual therapies for them, nutrient therapies, and recommendations of what medications. If a person is undermethylated by our diagnosis. And if they have low serotonin activity, that means we don't want to give them a medication that's going to reduce serotonin activity. A good example is dopamine. Some people have problems with too much dopamine activity or too little. One group that tends to have a lot of excessive dopamine activity are schizophrenics, classic paranoid schizophrenics, especially the ones who are tormented by hearing voices, who have a sensory disorder where their senses fail them. And so now throughout the world, if a person is diagnosed with schizophrenia, the treatment of choice usually is to give them a drug that will lower dopamine activity based on the dopamine theory of schizophrenia. So what works really well are folates and B3 niacin, because they tend to drop dopamine activity. Problem is they also drop serotonin activity. So you have to be careful. So we can, just knowing their basic methylation status, we can identify medications that are promising and not promising. For example, benzodiazepines, and there are problems with addiction tendencies, but they work especially good for overmethylated people, and they tend to harm undermethylated people. And there's a lot of both groups you need to know, so we can really assist psychiatrists in identifying which medications. Whenever we have a patient who comes to you first time and they're taking medications, drug medications, they don't call them biologics. I guess that's a more comforting name for publicity reasons, but they often can't wait to get rid of their medications. And we say, no, you must continue the medication and do both treatments together, because our nutrient therapies often take 2, 3, 4, or 5 months to really get the full benefit. And then after you've done both together, and provided that the patient has dramatically improved, then only then you start cautiously lowering the drugs. We are not opposed to drug medications. They've helped millions of people. I've had hundreds of people tell me how drugs have saved them and helped them. So we're not at all against them. However, it would be nice to use as little of it as necessary, because they have side effects and other problems.
So let's move on to generalized anxiety disorder, which has a variety of subtypes, panic attacks, OCDs, PTSD, and social anxiety. And so would you comment on that, what advanced nutrient therapy would do for these folks?
Okay, we have just recently now put together and beginning to publish the phenotypes of anxiety. And most doctors, including the doctors we work with, don't have the insight you have of the different types of anxiety. And there are 3 major forms of anxiety, and I think you already know what they are. For example, there are the overmethylated people who have excessive activity at norepinephrine primarily, and that means anxiety, and especially if they don't have enough GABA activity to balance that. So that's one of the major phenotypes, and that was the first one we knew about. Then the second phenotype, completely different form of anxiety, are people who have a copper overload. They simply have a metal metabolism problem in which they don't have the ability to regulate copper. Especially happens at hormonal events in females, like puberty, childbirth, later in life, and menopause. And what happens is during those periods, their copper escalates. And now after the baby's born, the copper level is supposed to go right back to normal, and more than doubles during that period. And high copper levels cause enormous increases in norepinephrine, which is an anxiety neurotransmitter, basically, and causes hyperactivity of norepinephrine firing. So that's one of the key forms of anxiety, and that's my favorite form, because all we have to do is fix their copper and they become normal. I know you've experienced that. And these people can suffer the rest of their lives if they don't know that. All it takes is a blood test, and you see their serum copper is sky high, and you know how to correct that. It takes a while. You have to be careful and cautious. But within 2 to 3 months, most of these people who've suffered many times for years are completely okay. So that's the second type. And the third type, you've already mentioned it, are the OCD type people that have the internal great tension and really very high anxiety. And OCD is an anxiety condition. And these people have this because of undermethylation. They're undermethylated. And this has a real impact on not the kind of anxiety where you see somebody walking down the street who you're a friend and you can see how anxious they are. Many of these people have great anxiety behind a calm exterior. You don't see it in their face or their actions. It's a completely different form of anxiety, but that's the third type of anxiety. We now can readily diagnose it, identify which form of anxiety a person has if they have generalized anxiety, and we have a roadmap how to fix it. And we also can suggest medications that might help if you want to employ them also.
I also see a lot of people suffer from anxiety who has also pyrrole disorder. Can you comment on that, about why it's not included in the phenotype you were talking about?
That's a very smart question, by the way, and I've thought about that. And the pyrrole disorder usually involves very low levels of zinc. And so these people generally have a copper-zinc imbalance. So the fact that they're so low, unusually low in zinc regulates copper. And so the pyrrole people, to help with their anxiety, is by correcting that. Really, for anxiety, we're normalizing their copper level. And that's why we put that together. But it's a subset of that one phenotype. It's a subset of the copper phenotype. So you're a very good, smart question. But that's why.
Okay, so it's a subtype of overload of copper, relatively speaking.
Yeah, the copper is regulated in humans by a gene called metallothionein. There are 4 metallothionein genes, and they have the responsibility for normalizing copper because it's so important for neurotransmission. For most people, it works beautifully. And I tell people, even if they were chewing on copper bars all day, if that metallothionein system was working, their levels would be pretty normal. But a lot of people don't have that ability, and there are SNP, single nucleotide polymorphisms in DNA for metallothionein. And now we know which ones they are, and they can really weaken that ability. And it turns out that the way the body normally adjusts if you don't have enough metallothionein expression is zinc. There is a metal regulation element in DNA adjacent to metallothionein, and it involves zinc. Zinc is what causes that to function and say, hey, we need more metallothionein, or copper is too high. It's really zinc that does that. And so we now understand exactly why. But if a person has pyrrole disorder, it means that they have a double deficiency, zinc and B6, and the zinc part is responsible for the anxiety.
Great, thank you so much. In my clinical practice, one of the most challenging type of patients has a tendency to be bipolar, quote unquote, or bipolar depression, or type 1 or type 2. And even though we discovered them having pyrrole disorder, they also have a undermethylation as well. And for some reason, just trying to correct these 2 conditions did not seem to have the same impact on them as we treat people, say, have just major depression or other diagnoses like OCD. And so it looked like bipolar has something more than what we know about. Can you comment on that?
First, I'd like to say, I think you've been asking me the best questions I may have ever received in an interview. Bipolar disease is different. It is not like depression. It's not like schizophrenia. It's a entity unto itself. It's unique and it's different. For example, it has the strongest genetic tendency of all disorders. It's far more, if your mother and father have bipolar disorder, you're about 80% likely that a child will have bipolar disorder. Whereas with schizophrenia, it's only about 30%. And so there's a stronger genetic tendency. But the unique thing about bipolar disorder is that, first of all, the median average age for onset is age 25. So it's a late onset disorder. And yes, some people have symptoms and things going wrong before the onset, But many patients, I've had hundreds of them. I've had a total of 1,600 bipolar patients that I've evaluated, and I have their chemistries. I've had many cases of people that were doing just spectacularly well in life, and then in a very short period, they developed very surprising anxiety and mania, and then were diagnosed with bipolar, and they had this problem the rest of their life. And they would cycle between mania, and the mania tended to always increase and worsen, and then suddenly shift into a depressive phase. At first, now sometimes there would be a period in between, for some people, a period of being okay between the two cycles, but for some people, it's very quick. And they can, as you probably know, bipolars can shift from mania to depression, a completely different condition. If you don't get effective treatment, they might cycle the rest of their lives. It's the most deadly disease of all mental diseases. It has the by far the highest suicide rate compared to schizophrenia and depression, anything else. It's far and away the most deadly. And one of the problems is that the depression in bipolar is different from the depression in other conditions, like regular depression or even the depressions in schizophrenia. So something's different. Now, about 7 years ago, I was not happy with our ability to help bipolar patients. I understand you're seeing the same thing. We usually can. We found that they do have, many of them do have oxidative overload or metal metabolism problems or methylation disorders or pyrrole disorders. And they usually report improvements, but they usually don't report that they're completely okay, that it helps a bit, but not nearly enough. And because it was so disappointing, I decided to spend 6 months just diving into new neuroscience research, trying to get insights or some understanding of why we don't understand bipolar enough. I mean, even though bipolar has been known for more than 100 years, 125 years, we still don't know what the cause is. We don't know what's the mechanism in the brain for cycling between mania and depression. There was nothing I could find that could explain that. And what we had was just generally trial and error use of medications, usually starting with lithium that was discovered accidentally by a Dr. Cade in Australia back in the 1950s. It was a complete accident where he was doing experiments where he was injecting urine from bipolar patients into guinea pigs that were family pets at his backyard. And he was trying to understand from this animal study. It was very crude. His problem was they didn't tolerate the high uric acid levels. So he decided to put some lithium in to enable him to get higher uric acid levels just by an accident. And he found that lithium made his guinea pigs calmer. He started trying it on people. It made bipolar patients a lot calmer. And it just started to spread. The problem was that some of the patients, human patients, died from liver or kidney failure, and it got banned for a while. But eventually they found that there are safe ways to use lithium. And so even that medication, which is probably the most effective drug medication for bipolar, was not because they understood bipolar disorder, but because it was just an accident. Okay, so I've now spent 7 years studying neuroscience, and I believe I found the answer. I think I have found right in all that new research. There are 250,000 neuroscientists in the world. And every month, there are more than 1,000 journal articles with new information. There's an explosion of understanding of how neurons and how the brain works. And very little of that has made it into clinical practice. And I think I stumbled on, I don't want to say I stumbled on it, but I believe, what it truly is. And I'm writing a book on it. I've been writing the book for a few years, and I'm very close to doing this. And a couple of years ago, I went to the annual meeting of the American Psychiatric Association, and I presented what I believe is the cause of bipolar disorder. And I'm quite sure this is correct. And what it is unique among mental illnesses. It is the inability for our brain neurons, our 80 billion brain neurons, to achieve the really high voltages or potentials that our neurons achieve. We have 80 billion neurons, but each voltage of these tiny little microscopic pieces of protoplasm, if you took 20 of them and somehow could link them together in series, you'd have enough voltage for a flashlight battery. There's you have amazingly high voltages. Well, the voltages, turns out, are enabled by about 400 genes. And most of these genes are ion channel genes embedded in the neurons that are responsible and enable these very high voltages. And what we discovered is that what happens, the reason a person may develop bipolar disorder, is that there are enough SNP mutations or a loss of DNA integrity that some of these 400 genes that collaborate to allow this are damaged to the point they cannot achieve the same proper high voltage. And that means mania. And then we discovered that if this happens, if you do a mass balance on these neurons, you find out that the mania will continually improve, worsen and worsen and worsen to the point where it can overwhelm parts of the brain to function. And some of the parts of the brain function very well because their history is full of people with severe bipolar disorder who achieved a lot, like Winston Churchill and Vincent van Gogh and Isaac Newton and a lot of celebrities today, movie stars and singers have achieved a lot. So we know that part of their brain is functioning well, but part of it doesn't. And it appears that what it does is it disables the RAFE nuclei of the brain, and that's what creates and distributes serotonin. So the depression in bipolar disorder, and by the way, people who are bipolar, and I'm sure you have many of them, if they're undermethylated, for example, and you give them SAMI or methionine that normally would improve this, you get very marginal limited impact. The reason is our treatments until now have been trying to improve reuptake. They don't have a reuptake problem. They have a serotonin poverty, and they need a different treatment approach. So I hope to get this book out, and by the end of the year, it's something I try. We're still working on about two hours every day, but I think it would be wonderful for the world to understand why it's different. We also understand why these people tend to have high pyro levels. It's unusual for any group like bipolar patients. It's about 95% of them at least have really high oxidative stress. Well, it's oxidative assault on DNA that damages their DNA integrity and results in many of these 400 genes prevents them from functioning properly. And that's why it's probably the leading cause for loss of genetic function. And so, of course, they still have that problem and it's still bothering them, but it's not that key to the condition itself. I think that's something that is hard to fight an enemy if you don't know what it is. And I think my contribution is I think we now have discovered and are clearly showing what it is. And hopefully the neuroscientists of the world and even people who are developing better drugs or better therapies can use this information and then not just trial and error, try and develop new medications, but actually go directly to what is causing it in the change in brain function.
I also noticed in the bipolar patients, they have a tendency to have a higher uric acid blood level. Is that the case you have observed?
We've seen a bit of that. One thing we've learned, I'm not sure if you're familiar with this because it's very recent. The research we're doing shows that most developed countries, that the incidence of undermethylation in human beings is dramatically increasing over the last 40 years. And there's been an explosion of cases of undermethylated conditions like OCD. There's an explosion of the incidence of OCD. There's an explosion in gambling disorders, which are associated with undermethylation. There's an explosion in drug abuse, heroin, cocaine, et cetera, undermethylation. There's an explosion in autism, which is a virtually always an undermethylated disorder. And I think there are now very clear, but not very well publicized neuroscience studies that explain why. It explains why we have now more than doubled the folate level in human beings just by giving everybody folate so women won't have spinal bifida if they get pregnant. We're learning a bit about that. And I think what this is going to lead to, I really believe from what I've learned about bipolar disorder, is that I think that this is a very complex condition. It involves many misbehaving genes, many misbehaving aspects of brain function and of human function, and very complex and very difficult to treat and correct. But it seems like it is going to be really relatively easy to prevent. I believe we'll be able to take an inborn baby, identify people who are prone to bipolar disorder, and be able to treat them so they will not receive it. I think that's going to be the future of bipolar disorder.
How does your discovery of cause of bipolar disorder and translate into any new blood work or urine test or any new nutrient therapy in addition to what we are doing now?
I think we should do what we've already doing. That is the pyrrole disorder and the metal metabolism and all of that. I think those are what we call concomitant conditions. There are things that can make treatment worse and make the patient worse, but I think they don't directly point at bipolar disorder. I think what's going to happen is that our DNA has 3 billion base pairs. It's really tied into the loss of integrity of key parts of the DNA, parts of the 21,000 genes, and some of them lose capability, which is why we age. It's why we develop heart disease. That's why we develop cancer, and why we develop bipolar and schizophrenia and all. And I think that the key is, as time goes on, we're learning more and more about each gene. We now know roughly between 90 and 95% of all genes. We know what they do and why they're important. Most of that's from animal experiments. What I think is going to happen, for example, we know which 40 genes regulate potassium ions. We know which genes are associated with glutathione ability in the body. We're learning that, but we've only begun to learn it. And what's going to happen is there are going to be genetic tests that don't exist today. And we eventually will be able to catalog all 21,000 genes and the 80,000 proteins that they can produce. And we can test a newborn baby and identify who has weaknesses and strengths in what particular areas. We'll be able to identify women prone to, say, breast cancer or other cancers. This is coming. It's going to happen. And it's inevitable. And it's going to be wonderful. I really believe that it's going to be primarily that. Then, of course, you're going to need treatments to cope with these problems. So there will be a large number, I think, of new lab tests. I'm hoping what my book will do is get all the scientists and people to study this and develop creative ways to cope with the problem that we've now defined.
You mentioned the words serotonin poverty. And what does that mean and how that affects we treat serotonin deficiency that we're doing now?
Okay, most of us, because of genetics, who are healthy and typical, when we're born, we don't have a lifetime supply of serotonin. It's created every day. All day, every day, our body is making more serotonin. Okay, we now understanding how that occurs. But some people are low in serotonin activity because of not just the amount of serotonin, but even more so the function of the genes that enable serotonin activity, the firing of serotonin neurons into the synapse. So what this means is that we have to have serotonin or else we're going to have a problem. And in bipolar disorder, I believe it's serotonin poverty because we've disabled the RAPE nuclei. I'm not sure I'm pronouncing that right. RAPHE nuclei, which are it's a part of the brain, mostly in the base of the brain, but the neurons go throughout the brain, and that's where the serotonin comes from. That's where it's produced. By the way, you don't have that in your body. The serotonin in your body is very important, but it's completely different. The synthesis of it is completely different from the brain. The brain, it all comes in the RAPE nuclei, and we know the steps. But if that's shut down, as I believe it is in most bipolar cases, then you simply don't have enough serotonin, and it can't be fixed by reuptake. It might be adjusted a bit. We need to somehow cope with that with treatment, and I think that will be people will be able to develop that now they realize if that's really the problem.
In Chinese medicine, which basically focus on the energetic imbalance, describe bipolar as excessive yin as a depression and excessive yang as mania. So, but still went through this cycle. And from energetic perspective, do you see the parallel between biochemical imbalance in bipolar versus energetic or electronic? Or is it basically the electronic changes that affects the serotonin functionality?
Well, I think as usual, the Chinese tend to have more insight in a lot of these things because they've been working for so many thousands of years. Yes, energetics are everything. And really, if you look at bipolar disorder, diminished voltages makes the neurons more energetic, and they fire more rapidly. You get hyperactive neurons, and that affects primarily, I think, norepinephrine and adrenaline. Those are the energy aspects, primary energy aspects of the brain, of neurotransmitters. And yes, it's energetics. And what happens is that when bipolar strikes, when the neuron voltages are not large enough, the voltages are too close to the threshold for firing. And so you get hyperactivity. The problem is that if you have a chronic mania, which is energetics really, it gets worse and worse and worse until you get to the point where you no longer can even form a potential enough to fire, and they just sort of shut down. There are scientific articles that show how that can happen to parts of the brain. Wow. And I think that's what happens in bipolar, but it's all because of this loss of the ability to form these remarkably high voltages for these tiny little microscopic neurons. Well, I might be wrong. I have to say that I'm not 100% sure, but I say I might be wrong, but I doubt it. Let's put it that way. It's not Bible yet, if you want to use that term.
Of course, there's so much to learn. And okay, well, let's move on to the schizophrenia. And this is another very confusing concepts, kind of a kind of basket of variety of conditions putting together. Yeah. And even by itself have so many subtypes. So from the biochemical perspective, and what do you say about schizophrenia so far we have learned?
You're right. There are probably at least a dozen different forms of schizophrenia. The major groups, however, the primary groups, for many years were what we call the overmethylated type. In other words, that had excessive activity at norepinephrine primarily, that was not balanced properly by GABA activity. GABA and glutamate, those are the two major neurotransmitters in the body, and they need to be in balance, and they get out of balance in schizophrenia. Now, it can go in two different ways. You could have low norepinephrine, and you could have low and high activity at NMDA, and those people, those are the ones that have delusions. They have a thought disorder. They usually don't have voices or the sensory problem. And so that's one of the major categories. The other category is the exact opposite of that. There are some who have excessive activity at norepinephrine and too little activity at NMDA. And they're the ones who have sensory problems, and they are tormented by voices and paranoia. We usually understand what in science before we understand why. But at least we know what, and we can now categorize the various types of schizophrenia, the leading types. But there are splinter types, many of them. You've probably already met people that didn't fit one of these three and needed something else. It's just where we are at this particular stage, clinical work. It runs in families. We're not quite sure which genes are misbehaving, but eventually we'll find out. We're going to find out exactly. As time goes on, we will know what I think at birth, whether people have predisposition for this. I think at birth, for example, we'll soon be able to identify babies with predisposition for autism. Now, autism only occurs in the first 3 years of life. Once a baby is past age 3, they're not going to become autistic. So that's a classic case of where we could identify those who are prone to autism. They're prone to their DNA sharply losing function in that early age during the development as the brain is being developed. And we now know that the weak link in our DNA is a nucleotide called guanine, Guanine. Well, we have enough DNA and enough guanine, and in these people that are having damaged guanine, that it shows up in the bloodstream. And we now today can analyze for that. We can identify babies who are prone to autism, and we know how to correct it. In that case, you would load them with powerful antioxidants to compensate, to protect the DNA, and you would also put them in an environment where they wouldn't have enough assault by the environment, whether it's chemical or cosmic radiation or whatever. So I really believe that we could eliminate autism from society within 10 or 15 years if people realize this. And actually, I've presented this at autism conferences. Nobody seems to pay attention. They're not interested in preventing autism. They're interested only in what do we do with these poor children with these very complex diseases. To me, it's like polio. You're too young to remember polio in the 40s.
Yeah.
But I grew up at that time, and that was a similar disorder. There were these little children, who were cripples, who made crippled by polio. And for 20 or 30 years, there was a huge amount of effort trying to understand how to help these people. And they were able to help to some degree, but still there were children in iron lungs. There were children in crutches the rest of their life, children who couldn't walk, people who couldn't walk the rest of their life. And how did they correct it? They found out what was wrong. They found out what was wrong and developed a vaccine. And now it's eliminated. I think that's going to happen to autism. I think it's going to disappear from society.
Actually, I was going to ask you about autism. Probably it's a good time to talk about autism. And what would you say to the young women who plan to have a baby? What do you tell them to prevent the happening of autism?
I think they need to have testing of key nutrients that they must avoid excessive levels of or deficiencies of. And I think paramount there is folates. We now know that folates, if a mother is deficient in folate, we now know that they are prone to spinal bifida and other neurological problems. So it's very important that they correct that deficiency. And if they do that, we now have clear evidence that conditions, spinal bifida and other neurologic problems, are disappearing or much lower levels. But what the world has forgotten is that how about women who are already, because of genetics, extraordinarily overloaded in folate? So that's one example. I think what needs to be done is a doctor, an obstetrician, or whoever the doctor is, needs to identify folate and a number of other nutrients. B12 is another one that seems very important. And there are others. And they're now doing these cord blood studies. Are you familiar with those? It's nobody's talking about it, but they're brilliant studies. What they are now doing is they're taking tens of thousands of mothers, and they're doing controlled experiments to identify the effect of prenatal care on the baby. And the reason is the cord blood, the umbilical cord blood, has the DNA of the baby. And at first they were doing this to get healthier babies, make sure their birth weight was higher and that they were just naturally healthier. They've done a lot of that, but they've done some recent experiments that are really interesting. They show that folates make your DNA undermethylated, okay? So they need to make sure that folates are in normal, healthy levels during a pregnancy. And I think that has a lot to do with environmental exposures too. I think we're going to learn a lot about how to protect a mother, how to protect the developing baby during the 9 months. And I think that's going to eliminate a lot of problems. I believe, for example, I've been doing recent research where we get an indication that we might be able to prevent schizophrenia. We're learning that schizophrenia risk has a lot to do with folate levels during the 9 months. And that women who are deficient in folate, they're prone to one form of schizophrenia, and those that are overloaded in folate are prone to, in this case, the undermethylated form of schizophrenia. And we have clear evidence that we can prevent or greatly reduce the risk of schizophrenia by normalizing folates, B12, and a few other important factors. I think that's coming. I think we can, I really believe in 20 years, we'll be able to eliminate schizophrenia from society if this is done properly.
So the current testing for B12 folic acid are reliable to judge whether we have enough or deficient or excessive amount of folate in our blood?
Well, they're not perfect. And there's always the challenge of, do you want to do whole blood cells? Do you want to do serum or plasma? And however, looking at this and looking at the experiments going on by these different organizations doing the cord blood studies, I'm finding that it doesn't seem to matter which one. It looks like plasma and serum are pretty much the same, and that actually it correlates nicely with whole blood and with red blood cell membranes and all those. So it doesn't seem to be critically important, the testing. But the thing that's surprising when you look into it is the question is, what is the range, the normal range? Doctors call it the 2 sigma range, the 95% range of folates in, let's say, women of childbearing age. It's very large. It's a factor of 10. So because of genetics, some people are innately very deficient in folate. Others are innately overloaded. I think their babies are at risk. But it's not only folate, it's other nutrients too. And it looks like B12 might be as important or more important, and possibly others. We're just learning. But folate, if a pregnant woman takes folates, their child will be definitely more undermethylated than if they didn't do that. That we know. 6 different organizations have found. And these organizations, when they first discovered this, didn't want to report it. They were nervous because folates, they're methylating agents. They're effective at methylating. But if you give them to a pregnant woman, their DNA becomes undermethylated. And now we understand why. We know the mechanisms. But that's something the world doesn't recognize yet. And they will quickly. Well, myself and others are going to report this. I mean, it's going to be something that's really important for human beings. Wouldn't it be great to get rid of schizophrenia? What a terrible, cruel disorder for a family or for an individual.
Yeah. So the increased amount of autism, a lot of schizophrenia, in recent years, have a lot to do with the increase of undermethylated babies that we're creating.
Yes, and now we've had foundation research studies on schizophrenia. And what we found, to our surprise, 3 years ago, was that the overmethylated form of schizophrenia is disappearing from society. This is how we stumbled on this. We stumbled on it, and we didn't expect this. And we were trying to get, we were doing a controlled study of the 3 major phenotypes of schizophrenia: overmethylation, undermethylation, and the pyroluric version. We couldn't find the overmethylated ones that are disappearing from society. We checked with other groups and looked at huge databases, and it's true. Well, the more than half of all schizophrenics were overmethylated 40 years ago. It's below 10% now. They're disappearing from society, and I think we know why. Well, meanwhile, the undermethylated patients, and you've seen this, I'm sure, you're seeing much more undermethylation than overmethylation.
Right.
This is why. It wasn't that true 40 years ago. It was balanced, not anymore. And we can control that, and therefore very likely control the risk for many of these diseases, mental diseases, and I think physical diseases. I think we can have a good chance of identifying people prone to cancer. I'm sure of that. Nobody is, I go to meetings of experts from around the world. I pretend that I'm a cancer expert and I don't know anything about cancer, but I pretend I'm one of them because that's where the great epigenetic research is going on. So I'll go in there with like 35 or 40 real experts from around the world, pharmaceutical companies, university specialists, and I listen to their cancer research. And what I've learned made me angry, to tell you the truth. I mean, there are quite brilliant biochemistry and genetics and treatment approaches they're all trying to develop the next billion-dollar drug, and they're making progress. However, they also understand why cancer is caused. They understand the reason for it, and they know how to prevent it. At least and nobody seems interested. But that's the answer for cancer. It's going to happen. And it has to do with DNA integrity.
Yeah.
When a cell stops functioning because of DNA not functioning sufficiently, one of three things can happen. You can have senescence, where the cell just sits there and does nothing, or you can have apoptosis, where it is consumed and leaves the body, or cancer. So the thing to do is to work in that direction. And I think you can analyze the nucleotides of DNA and identify the ones that are damaged. And if you get a really high rate of guanine damage, for a woman, that might mean that her BRCA gene that prevents breast cancer no longer is functioning.
Right.
But you and I know what to do to help these people if that's the case.
For the autistic children, they already got it. And is anything can be done?
Well, one has to focus on, I've had, at one time with my clinic, we had the largest number of autistics in the world, and by far the world's biggest chemistry database. We have 6,500 cases, and it's such a cruel disorder. I mean, it's heartbreaking. Every case is heartbreaking. But what we learned is that if you get early intervention, if you can begin treatment before the age of 3, you have a very good opportunity to treat the disorder, make it far less significant, and in many cases, essentially cure the patient. And we have many of those cases, but we have many more that we began at the age of 6. You can get more progress with a 2-year-old in a month than you can in a year with a 6-year-old. Early intervention is so important. It's got to be diagnosis. There's also a problem lately in misdiagnosis. These autism spectrum disorders, they are not autism. They're completely different from classic canner autism. And more than 2/3 of all people now diagnosed as autism spectrum do not have autism. Their brains develop more normally. They're not. Whereas autistic brains, if you have a child with true autism, by the time they're 10, 12, 15 years old, if you analyze their brains did not develop normally. They did not develop normally. Now, one thing I think is really important is metallothionein, which I mentioned before. One thing we learned in our database is that virtually every autistic child has extraordinary copper-zinc imbalance, and metallothionein is not functioning. And we know that metallothionein is not only important for copper regulation, it's very important for development of the brain. It has so much to do with the brain actually developing. We think that's one example of something that you can do for autistic children. But you need to correct their mental metabolism. They're all undermethylated, every one of them. 99% of true autistics are undermethylated. And yes, you can help them with our therapies, but you need to do it before the brain development is completed. And by the time of age 3 or 4, 98% of brain development is completed. And if you don't correct that early, they're going to have those problems, some problems, the rest of their lives.
So the earlier treatment definitely is more productive, but the correcting their biochemical imbalance like undermethylation still useful even the children are older, right?
Yes. Yeah, I'm sure that I can't explain in detail exactly the mechanisms, but I think it makes sense that to normalize that important aspect of a baby's development, because we now know that methyl bookmarks, whether they're attached or not attached to promoter regions next to every gene, that determines the rate of gene expression. So if your methylation is abnormal on your DNA, your gene expression will be abnormal, your brain development will be abnormal. Now, you and I think, are both undermethylated. Am I right? There are advantages to being undermethylated, and there are negatives. The advantages are people who are undermethylated are competitive, they're determined, they don't give up, they tend to be OCD. And if you channel that into a career or into a sport, all the great athletes are undermethylated. I've tested some of the greatest athletes in the world. I used to work with Olympic champions and champion boxers and the really good ones are really undermethylated. They just want to succeed. And a lot of them become doctors and scientists. The negative is they're prone to low serotonin depression. They're prone to obsessive compulsive disorders. They're prone to addictions. If you were to do a study of people who are heroin or cocaine addicts, most of them, you'll find a strong tendency of undermethylation on and on. So there's positives and negatives. Maybe you and I have been somewhat lucky to avoid the really bad things that could have happened.
I think one thing they will be afraid if we correct their undermethylation, they will lose that competitive edge. Is that possible?
We worried about that, but we now know it's not true. And the reason it's not true is the methyl bookmarks on your DNA are permanent. When we treat people and try to affect gene expression, we're not changing those bookmarks, those innate tendencies. We're not changing them at all. They remain. So one thing we learned after doing tens of thousands of patients is that if you take an undermethylated or an overmethylated person and adjust their methylation in the body, it doesn't change their symptoms and traits. It really doesn't. If you have a obsessive compulsive disordered person and you know that they have their DNA is undermethylated, doesn't have the right number of these regulating methyl marks on their DNA, that's not going to change after you improve their methylation, and they're still going to be competitive. We've taken great athletes and made them better athletes because we could eliminate their anxiety, but we didn't eliminate their capability. We were concerned in the beginning that they might lose the nice part of that, the nice part of the undermethylated.
Okay. So we're going to finish with the last question because you mentioned that 2/3 of autism as autistic spectrum disorder do not have the autism. How do we separate them? How do we differentiate them in our diagnostic process?
Well, let me try to explain quickly. For back when I was running the Pfeiffer Treatment Center, we did a number of scientific experiments with universities and with the government. And the reason was we had this huge number of autistic families coming every day. We might have 10 or 15 families every day coming to our clinic with an autistic child. What we did is we got the approvals, did the ethics, and got the approvals to take blood samples from classic cases and do that in conjunction with researchers from universities and others. And so I had so back in, I think it was 2005, well, early on, from 2000, 2005, I had a researcher who worked for me, and every time a family would come in, I had them study the case to determine whether or not they had classic autism that would be suitable for an experiment where you want to be really careful or not. And up until, actually it was 1995, what was happening was that this is like one time in 100, there would be something else, and it wasn't quite right. Maybe a head injury or deprivation of oxygen at birth or a more of a developmental disorder. But in general, almost all the cases were proper for the experiment. And then right at that time, over a period of 2 or 3 years, there was a huge change. And it was because of this whole idea of autism spectrum. And it happened originally because of financial reasons. That autism spectrum was becoming, there were people who were giving tests and treatments, and there were autism doctors, and I hate to say this, but I think they just wanted to have more and more patients. And what we found was that after only 2 or 3 years, we no longer, when we would test the incoming children diagnosed with autism, that more than 2/3 did not have autism. So we had to be careful to select those with what we called true Kanner autism. Kanner was the man who first discovered autism and reported it. And those are the people who get better because they don't have their brains not properly constructed. And so there's always doctors and others and families saying, how wonderful, my autistic child is no longer autistic. But you can easily tell. I now have patients who come and say, my 10-year-old has been doing pretty well in school, but he now has this autism diagnosis. Well, there's 11 classic symptoms of true autism, and he might have 4 or 5 of them, and but not have the case. If a person has true autism, they're not going to be speaking properly at the age of 3. they're not going to be, there are all these things that true autistics cannot do. And it's so heartbreaking for those families. But it's a different animal, so to speak.
Dr. Walsh, thank you so much for the time,
talking to you,
knowledge, and I have to say, to be continued. I would bother you again, and we'll talk about your new books down the road. And we have many questions from our patients, our audience, and so periodically I will come to have you talk to them again. Thank you so much.
I want to mention that we have a new program, and we now have more than 1,000 doctors like yourself, although many of them are not as capable as you, but we have more than 1,000 doctors who are now doing this. And but a lot has happened in the intervening years. There's advances in neuroscience, advances in biochemistry, and we now know about and so we're having in January, we're having our first time, we're going to have a 3-Saturday updating session where we're going to invite everybody to see all the new advances and what we've learned. And we hope to do that every year too. I think there's a problem in talking to the doctors that we saw started 10 or 20 years ago, that a lot of them aren't aware of all the new advances. And so we're hoping that this will keep everybody sharp. And people like yourself who now have large numbers of doctors that you're assisting, you'll be able to keep them up to date with the latest. So we're hoping that that'll be good. Good talking to you. You've asked some of the best questions I've ever had. I've been interviewed hundreds of times. You're in the top 10 with asking really good questions.
Thank you so much. So talk to you soon.